Welcome to Profound Conversations. I'm Joya Jefferson Nuri, and I am your navigator for today's program. This is program number 4 of this season, and we have been looking at justice, equality, and all of the things that we need to balance out. And over the last few weeks, as we saw the verdict in the Ahmaud Arbery case, it gave us an opportunity to reset. Everyone got a verdict that says that there can be justice, there can be fair, and people of good hearts will make a choice that says, despite race, an injustice has happened and those perpetrators must go to jail. A gleeful sound came out across the country because it was a big deal when case after case after case before this did not end in the same level of result. The Ahmaud Arbery verdict allowed us to reset as a nation, or have the opportunity to reset as a nation. And it also begged the question, is it time to reset in the medical and public health field? There have been a lot of disparities that have caused quite harm to people of color and national origin that was not American. So now we have this reset button that we have, or possibility to do it. In our earlier episodes, that we have affirmed a few salient factors. I'm going to read them to you. 1, lack of trust creates inconsistency in the delivery of care and influences patient family choices and outcomes. We also came to the conclusion in previous episodes that coalition modeling containing co-work principles successfully establish trust among people within organizations. And for our two guests today, Dr. Zach Berger and Ms. Kelly Raynham, they are experts in the public health field, and I'll go through their backgrounds in just a moment. And if you want to know more, you can go to our website, and that'll be available for you. In this reset, Dr. Berger and Kelly, we have the opportunity now to say something different and do something different. And I just mentioned what did I call it? Co-work principles. The co-work principles were laid out in one of our programs by one of our guests. And fundamentally, it is taking a real assessment of who your cohorts are, who the co-workers are. Now, the co-workers can be your colleagues. The co-workers can be a connection of organizations that you're working with. How do we work together with all of our co-workers when we have a history of mistrust of, obviously, not just the police system and the justice system, but a mistrust of the medical system? A lot of African Americans are leery of experiments that left Black men with syphilis just to see how it was going to go. Kelly, that there's a big fear of being an organ donor for fear that the hospital would let you die so that they can harvest or gather your organs. So we're here in this place, and we want to start to articulate what we do. How do we build this trust now that we know that it's possible in our time that people can see things differently? And I'm going to start with you, Dr. Berger.
Well, I really appreciate the thought about co-workers and collaboration. And I think I really want to, and that's not something I hear enough about when discussing trust. And I want to really explore that and thinking about what different kinds of collaboration are possible in our healthcare system. And just thinking about the people I work with every day, and what would it mean to really collaborate on an equal level and eliminate our hierarchies. And just thinking about my institution, not blaming my institution specifically. This is unfortunately characteristic of most academic medical centers in the US, that the certified medical assistants, the community health workers on whom so much care of our patients depend, don't get paid enough. It just is very honest, right, to say that. And the vast majority of these workers are African American, right? The vast majority of these people, specifically actually, the community health workers, are hired because they live near our patients. And they're treated just as poorly as our patients are, in the sense that many of these institutions have a great deal of money that they don't share with those around them. So a real coworker shares equally in your costs and benefits, I think. So that's one thing I want to say. The other thing is, seeing a patient as a coworker is also, I think, a farther distance, but also a really necessary thing. What would it mean to work in actual collaboration with the patient to do what they want, and to, again, have them share equally in benefits and risks? What if they were paid for their time? What if all these things come to mind about what true collaboration would look like? So I'm really glad you brought that up.
Yes, thank you. And for our audience, Dr. Berger is an associate professor in the Johns Hopkins Division of General Internal Medicine and core faculty at the Johns Hopkins Berman Institute of Bioethics. Thank you for that. Before I get to you, Kelly, I want to follow up on something you said. You asked the question, what would it look like if you were a coworker with a patient? What would you think that would look like?
Yeah, well, I think, so much of how I've learned to think about the healthcare system in the past few years is materialist. That means, and that's sort of, that I mean that in the specific sense of the word, like economics, money, right? So much of our healthcare system has to do with who does or who doesn't have money. So if you're someone's coworker and you're really in a collaborative workplace, say it's a co-owned business, right? People share in the profits, right? People share in the resources, and you don't treat people differently if they have less money or more money. So that would be one step. And the other step is a real co-owned work environment, as people work together to figure out what the goals are. So in our system, so often there are metrics that institutions aim at to maximize their revenue, and it's not really what the patients want. And we tell ourselves that it's good for the patients. That's not the same thing.
Mm-hmm. You also, Kelly, I will get to you, but Doctor, okay. Doctor, you also said if you were to work with the patient in order to do what they want, what would that look like?
Yeah, I mean, I think it really depends on the patient, but I think, so often, I'll tell you about one group of patients that is really that we've really presented with challenges, that we've made them jump through hoops, and that is, and I'm sure you all know, because it's a very common condition, people with chronic pain, right? And there are a number of treatments for chronic pain, and they're all not really good. They're all sort of moderately good. And many patients, unfortunately, have need of opiates, of narcotics, which can be effective in certain people. And like any medications, have pluses and minuses. And our institutions, as a general rule, have decided that opiates should not be given to people with chronic pain. There are some exceptions, but people are made to jump through hoops. And that can lead to real patient harm. Mm-hmm. So working with patients to understand what they find helpful for their pain on an equal level, I think would change how our institutions see things. Now, I'm not saying it would solve all problems, because pain is difficult to treat and it demands a very broad approach. But seeing patients not as suspicious characters, but as co-workers, I think would be appropriate.
Thank you very much for that. Kelly is the Chief Executive Officer of the Louisiana Organ Procurement Agency. Kelly, the question goes back to you. The same question, co-workers, expanding the idea of course, you work with other organizations and you do collaborative work with other groups, but to be a co-worker with everybody involved, including the patient and the patient's family.
You're in our field, we do have to work really with everyone. So from the coroner medical examiners, funeral homes, hospitals, donor hospitals, the families, and the transplant centers, which is just another faction of the hospital itself. And it is often, I think if we looked at things much like Dr. Berger said, that we were actually coworkers and we were not competitive or in separate organizations, that we were all one, I think that the system would be so much better. And I think that faith in the system would be better, and possibly people wanting to donate more could be an end result of that, knowing that they're getting good information across the board, transparent information, and they're being treated fairly and presented all options. And I think that's not what we do at all. And it's unfortunate. And yeah, there's just so much to do. And I really didn't even think about the certified nursing assistants, like you were talking about, Dr. Berger. And I think that is such a valid point. And for us in the organ procurement side, the donation side, we tend to focus on the nurses. But when I step back and look through your lens, I think it is the housekeeping staff, it's the security staff, it's those the nursing assistants that are there day to day with those patients and those families and spend more time. They're the faces that are familiar to them. They're the faces they're comfortable with, and yet they're pivotal to our process. They're pivotal to the care that patients get in the hospital, maybe not the direct bedside medical piece, but the feeling a part of or being taken care of. And I think sometimes when I look back at some of the things I've experienced as a nurse, first off, but then also as a coordinator that used to do cases, they were my go-tos, and you know, the security staff, the nursing assistants, because they knew, and I felt like I got better answers from them. And I just never really kind of put that together until this moment about the disconnect in pay. And yet, you know, there probably are very pointed reasons for why they're hired and for the roles that they're hired in, but you're not really giving them the credit financially or otherwise for actually that pivotal role that they play in healthcare and in providing some form of trust at a hospital level. And I think that, you know, for me, walking out of here today, I'm absolutely going to embrace working with more people in the hospital and explaining that they do have a role, even if it's not at the direct bedside, to helping the community. And then, you know, when I kind of flash it forward a little bit more, if those people that work in the hospitals, the nursing assistants, the dietary staff, housekeepers, if they're mistrustful of what they see on a day-to-day basis, and that goes out into the community, that's what the community hears. And why should I believe you, nurse, when, you know, people that I go to church with, people that I live near are telling me something different? And I think that's absolutely where more community and collaborative and coworker relationships would really come in handy. And I loved listening to Karima, and, you know, community work is messy. And I 100% agree with her. And I think it's time for us to get messy.
If I could add something, I think a friend of mine by the name of Josh Garoon, is a sociologist in Wisconsin, came up with a very useful term, which I want to share. It's healthy mistrust. And why is that term useful? Because so many people, you know, I think it's really important. One thing I have to remind myself of every day as a clinician is people's choices are constrained by their circumstances, and people generally try to do things for reasons, right? People aren't, you know, even things that we might find hard to understand. You know, people, when they don't want to get vaccinated, they have reasons, right? When they don't go to the doctor, they have reasons. And if they're not trusting the system, it's often because the system has done them wrong. So, you know, if you're in a relationship and it's a hurtful relationship, you're not going to trust that other person unless you've figured out there's some sort of concrete change. So this is a healthy mistrust, right? That people demonstrate.
Do you know the title of this particular episode of Profound Conversations is Reimagining Trust, Engaging Hearts and Minds in Community Throughout America. The term unhealthy mistrust, Doctor, is an acknowledgement that people aren't making this up. People have real reasons not to trust. I have a dear friend who was hospitalized in Atlanta. He's in his early 70s. When he went to the hospital, he's in jeans, and it looks like people look like when they go to the hospital on a Saturday. And he's diabetic, and nothing aligned with his level of blood sugar levels were at 300 when 100 is normal. But he didn't have any kidney failure. He didn't have any internal damage at all. And when they got the sugar levels down, the blood sugar levels down, his joints started to ache. They kept telling him there was no relationship between his blood sugars and his joints. And instead of being a co-worker with him, they kept telling him he was imagining it. And he's a man in his early 70s, but the doctor treated him like, you're dumb. The doctor nearly dismissed him, and the doctor actually said to him, I know more than you.
Oh, goodness.
And he said, I'm smarter than you about this. But he looked at an elderly 70-year-old man and categorized him, until my dear friend said, I have 2 Harvard degrees. I run a $2 million business. You're just looking at my physical. Now you have an oath to do no harm, and you just did that. Mm-hmm. What was most appalling for that was, one, the doctor assumed, and the doctor was arrogant enough to say that out loud. But I don't think that would have happened had my friend not looked like an old elderly Black man in jeans and a dirty shirt. I mean, because he went to the hospital on a Saturday afternoon. Right. Like we all look like on a Saturday afternoon. Right. And why did he have to prove? Now, the doctor's attitude completely changed. They kept him for a few more days and really looked into this, because my friend threw out a credential. Mm-hmm. If we're going to co-work with each other, and if we are going, as we say in this, reimagining trust, how do we do that? From both of your perspectives, how do we do that? And you, Kelly, were talking about reimagining the trust with the people who are on the front lines, and so did you, Dr. Berger. And so if you have to reimagine your trust with the frontline people, because when I've been in the hospital, that guy that comes in with a mop is probably the friendliest person I see in the hospital. Okay. Yes. He stands and asks to see if I'm okay, if I need anything, so from the guy with the mop to the doctor who I only see for 15 seconds. Mm-hmm. Okay. How do we reimagine trust where a doctor would never say that to his co-work patient, no matter what he looked like? He didn't need the Harvard credential.
My first answer would be, so part of it is about power, who has control, right? And if certain people have control and certain people don't have control, that's going to affect people's care. And just to be explicit, right? Like, Black people have not been given control of healthcare, right? And there have been efforts to change that. I'm thinking of the history of free clinics in the 20th century in the U.S., which start with the Black Panther Party, right, and their free clinics. Mm-hmm. And so you have to redress disparities of control. That's part of it. Another part is, and I'm going to throw out another term which I like, speaking to the story of your friend in the hospital, that the term is epistemic injustice. And for those listeners that might not know what that means, epistemic means having to do with knowledge, right? And that means you are discounting the knowledge of the person you're talking to in an unfair way. So what would it mean to really listen to people and really take their knowledge into consideration? Well, we tend to fail to listen to people who we consider lessers to us, right? So it requires, so some of this, as a piecemeal strategy, I think it's always useful to try to teach my colleagues and people about listening to patients, listening to everybody, and to be more compassionate. Those are great things. I'm not discounting that, but you really need systemic solutions that have to do with distributing power and resources more equally.
How important is humility in that equation?
I think it's very important, right? So knowing what you don't know. There's a famous curve. At the beginning, you don't know what you don't know, right? And then as you practice for a number of years, you begin to know what you don't know, right? And so you have to. That's a humility. It takes time to learn. And I think I've made so many mistakes and learned so much that I feel pretty confident in my humility. So that's. I think it's an important ethical trait.
Mhm.
As you can tell, I'm pretty conflicted about whether ethical traits are enough. I don't think so. I think that when we tell people to be more ethical, we take the system off the hook and put it all on the individual. So even if we were all the best people possible, right, that wouldn't redress power and resource imbalances. But on the other hand, I do believe that a humble doctor or nurse is a better doctor or nurse.
Thank you, Dr. Berger. Kelly.
It's odd in that as nurses, when you deal with doctors, you see a level of what you just described to your friends, right? You don't know, I'm the doctor. MD means my decision, kind of thing.
Oh my God!
And haven't heard that yet.
Oh, no, I have. I thought it was gone the way of the Bee Gees. I'm sorry.
Yeah, I was hoping so too.
Yeah.
So I do think that, in working with physicians, particularly surgeons, I can't imagine what it is to have a heart in my hands or a brain in my hands. And I think that humble has to go out the window in surgery, right? And this overconfidence has to come in to be able to do the job. But how do you learn to take that hat off out of the OR and have the bedside manner outside of that OR? But I think that it just comes to all of us understanding diversity and whatever that is, whether it's age, whether it's religion, whether it's race, whether it's socioeconomic status. And I think that that's kind of where we miss it. We know who we are and all the people like us, and you have to want to work hard to understand something different and understand differences. And I think that doesn't necessarily get brought into med schools, nursing schools. Maybe you get a little basic sociology class or a psychology class, but I don't think we spend enough time on it. And I've found here in my own organization, actually really talking about diversity and equity and inclusion, and that it's not one color, it's not one religion, that there's so many variables, and that if you have a class, you're not done with that. You have more, it's continuous, and you don't just get a 4-hour lecture and all of a sudden you're an expert, and that you have to be humble, that there's humility in not knowing, right? And you have to be smart enough or vulnerable enough, maybe not smart enough, but vulnerable enough to be able to put yourself out there. I mean, there are just times when I say something and then I think, oh, did I say that the right way? And I didn't want to offend anybody, but I want an answer and I don't know which way to go. And I think that that's what we need to learn as human beings. How can we interact and learn and grow from each other without these preconceived notions? And I think in healthcare in particular, it's never really a big focus of the education that you get when you're going into these roles. And
yeah, I think that's really, you said it really well. And I want to pick up on something you said earlier, which is that this is messy, and thinking about how to co-work with people and how to listen to people. I think that's an important point. It's not like kumbaya, everyone holds hands and everyone feels good about it and everyone smiles at each other, right? Like really working with people involves conflict and dispute and working well as a team doesn't mean everyone obeys everybody. It means people have differing opinions. And that seems like a cliche, but I do think sometimes organizations like to paper over disputes. And this is why, for example, organizations generally or often don't want to see workers organized, right? Or don't want to see unions, because that implies that people aren't getting paid enough and bosses are making mistakes, right?
So they need
So
protection.
what's
When
that? Protection. That's right. Absolutely right. That's right.
Right. Kelly, you said something. You said you should be continuously learning, that you don't just take a 4-hour workshop and then all of a sudden you're an expert on DEI or anything. Okay. Be continuously learning. And what struck me when you wrote that, when you said that, I wrote this down. It's that I'm thinking, I'm asking you both, should we not also be continuously vigilant about our biases, our arrogance, and our superiority? Yeah, either one can answer that. Should we not be constantly vigilant as an organization and as individuals who have some measure of say so or power in our community? Should we not?
What were the things you said after biases? There are two other things.
Arrogance
and
sense of superiority.
I mean, I guess I would say, I think it's important to be aware of one's personal biases. I have to say, a lot of the DEI language recently has been window dressing. You know, I obviously, you have a clinician, you have a worker, you have a patient that says something racist, right? That's bad. You don't want that to happen, right? And we've all learned in the public sphere what happens when leaders match their course language, their course policies. So it doesn't make it better if you have coarse language, it makes it worse, right?
Yeah.
So it's the conflict between ethical behavior and systems behavior and changing policies. So I don't think it's the case that if everybody were to eliminate their personal biases and arrogance, everything would be solved. Like, that's not even the first step. That's sort of a parallel track, right? I want to make sure I'm saying I'm behaving as an excellent collaborator and acknowledging my privilege, and this is the way I am, and so I'm coming from a particular place, and so there's a lot of things I don't know. I want to acknowledge that. On the other hand, like, the fact that our healthcare workers aren't making a livable wage, that doesn't have much to do with me being a nice person or not being a nice person, right? Doesn't matter much. So again, these parallel tracks.
How do we start that? I totally agree that me eliminating my biases is not going to change the injustices that happen all along the systems that we live in. But Dr. Berger, where do we start? If we're going to reimagine, where's the reimagining start?
Yeah, well, that's a tough one. If I if I had the solution to that, I'd be, I don't know, maybe I'd be a prophet or something. But I think it's a large political question. I think it really starts with organizing people to share resources and build different structures than the ones our governments have, because our government structures are often failing us. So it means bringing people together in groups to try to remake things. And I've been really inspired recently about the history of community healthcare and solidarity-based healthcare in the US. There's a community Muslim clinic I've been reading about in Montgomery County, Maryland. There's the Black Panther Party's clinics, which I mentioned earlier. There are Native American clinics. So healthcare that's owned by the patient is maybe one way to go. But it's all about organizing people and trying to use the power of the people.
Yeah. I remember that phrase. I'm old enough that has been a normal life.
Yeah.
I remember that was a goal at some point in our young people's political movement, power to the people.
Yeah.
Can I ask you the same question? Where do we start the reimagining?
I think, in some degree, you do have to start with yourself so that you can realize what's not fair and equitable out there, right? Where you need to start. And I 100% agree. It can't just stay with just you. That's not going to change everything. And I think that knowledge that these systems are broken and why they're broken, and how do you start, even if it is just that people, a community owned clinic that actually the community will go to, because there's some faith there and some trust. Whereas if you just pick up and plop down, the John Hopkins Clinic, or here in Louisiana, the Auctioner Clinic, those same biases that exist for the hospital are going to carry over into that community clinic too. So, maybe that's a great first baby step, is connecting with the community to meet the community's needs and use the community to inform how you do that and give them the resources. And I think for me, the frustrating part is all this money is thrown in all these different directions and yet nothing's happening. And I think it's been that way for many years, probably all of my 50+ years in this world. And so, yeah, where do you just put that hammer down and say, we're just going to start doing it. We're going to quit talking about it. We're going to quit politicizing it. We're going to try this and see if it works and go from there. And I think that's really, we just have to start acting and not just talking.
How do we redirect that money? I mean, how, Dr. Berger, it's like people come together, community clinics, but there has to be somewhere in this reimagining that, you're right, Kelly, it's not landing where it needs to land. The frontline people are not being paid well enough by big institutions like Johns Hopkins and above. And in these community clinics, we can imagine nobody's getting a salary they can live on. So Kelly, what do we do to help redirect the money?
Well, that's a great question. After spending some time in DC, I don't know that that's the answer. There's so many forces, coming in.
Without DC, we definitely do it without.
Maybe it's starting at a city level, a county level, and then moving to a state level. And maybe it is those small grassroots steps that are more connected. Not just in your one little town, but that little town that looks like you in Maryland or in California or in Missouri. They have a network to connect, and then all of a sudden these voices can grow. And hopefully, if there's some modeling and it shows that it's successful, then you start listening, right? People start listening, particularly if there's money saved, meaning you're not having repeat people in the hospitals for conditions that could have been taken care of better on the front end. So maybe that's a first step. I don't think I'm the first person to even say that, but you're right. How do we actually make it happen? How do you?
I love what you're saying about networks. I think that's really important, building networks. And I think one way to think about it is, where the money is coming from. I sort of sound like a broken record, but I'm a firm believer of redistribution, right? So there's no reason for there to be billionaires, right? So there needs to be redistribution of those resources. And there's no reason for healthcare institutions, I'm talking about Mayo, Harvard, Cleveland Clinic, Hopkins, not to pay their fair share of taxes, right? So to mention a little bit of good news, I just saw a report in a New Haven publication about how Yale and New Haven have negotiated a deal where Yale is giving more money to the community. And that's a way to build trust. I'm not even saying rebuild trust, because I know something about the relationship between town and gown and New Haven and other cities, right? There might not be any trust to rebuild, but you have to build trust, right? So it's about having institutions with a lot of money that was not given them for cleanliness of soul, right? But a way to redistribute that resources to the people that need it. And that means paying a fair share of taxes. So that's one way of thinking about it.
I'm wondering if another way to think about it, I'm throwing it out for either one of you to answer, is to go for the foundation money and ask them to do better. The Kellogg Foundation is very dedicated to nutritional health for children, and they give money, but are we sure that that money is earmarked to make sure there are better salaries, better conditions, better facilities, better distribution of the healthcare, or are they just looking at a proposal and granting money?
Mm-hmm.
Would that help if foundations if networks could get to foundations to say, this is what we actually need. We know that your mandate is to do this, but this is what we actually need.
Mm-hmm. Yeah, I think that's something worth thinking about. I think a lot of the issue or the barrier in thinking about that and thinking on that way about foundations is similar to the issue about thinking about DC, right? Foundations, like a lot of nonprofit organizations, like a lot of elected officials, are not necessarily accountable. So they have to be pushed, right? And how do you push them in the right way? But yeah, I mean, if you're, you know, where's the, you know, what the robber said, we're asked why he robs banks, right? Because that's where the money is. So you have to go where the power is, right? And that's the foundations. And so you have to, you can't say, oh, I don't have to deal with money, I don't have to deal with all this. You have to figure out how to move that.
Yeah.
And
Kelly?
I do think with you know, the foundations, it is a spot that has, you know, the finances that you can actually directly go to and apply for, right? Versus trying governmental funds. And but I think sometimes maybe if it was true community activists from the community that were the ones that were listened to for this funding, and then not just give the check, but how about giving them some assistance on how to set the business side of things up? Maybe you have this brilliant idea of how you can help your community, but you don't have a college degree with that, how to establish an entrepreneurial business and how to set it up and what the HR things are and what are the legal things. And so, I mean, I think that's not writing a check, but really helping people to do the work, or providing the resources to them to do the work, because they are connected. You know, the more money, I agree, power, money, they have connections, they have the knowledge that, you know, sometimes people that just want to do good work don't have. And I think that would be very powerful to connect it.
So to have mentoring
Yes.
along with the check, it comes with manpower along with the check. That sounds really empowering for the community. That would empower any entrepreneur. Maybe more small businesses wouldn't fail and there would be more money in their community, you know, since small businesses fuel our economy, but people don't know how not to get tripped up by the IRS or not to get tripped up by Bank of America, you know, so they don't know what they don't know, as the doctor said, they don't know what they don't know until somebody who knows what they don't know can come in and help them. It seems like what we've done in this nearly 45 minutes we've been on the air, we've expanded what coworker looks like. You know, really beyond what I listed in the beginning, what the co-working has to have so many different layers. Any comments on that?
I think understanding that we're all working, you know, we're all workers in a capitalist economy, and patience, you know, this is an important point that Victor Montori, who is a researcher and clinician at the Mayo Clinic, has made a lot, that being a patient is uncompensated labor. Like the amount of effort it takes just think about diabetes, right? Just checking your sugar all the time and managing your diet and picking up your meds and seeing the doctor and the specialist, right? And that's as a chronic disease, that's not all that exotic, but the amount of work, right? So thinking about what it means to collaborate with people and recognizing the value of their uncompensated labor, I think, is a really important point.
Exactly. Kelly?
Yeah, I also, I'm kind of wondering, you know, aren't there other models out there that exist in other countries that are successful that maybe we could learn from a little bit more? So off your question, but this sort of popped into my head. It just seems like we always think we have to have the answers, and we try to stay within the confines of what our system already is instead of looking outside of what it could be.
Yeah.
So
I don't know, Dr. Berger, does American medicine go look for models from around the world that you've heard of?
I guess the short answer is no, not generally not. I think there's a lot of, I just take the example of you know, Medicare for all or single payer healthcare. There are plenty of countries doing different things, right? And in certain political circles, it is really not allowed to talk about Canada or the UK or France or Germany, right? Or Singapore, or right, or you know, a number of countries in Africa or Australia, wherever. You can't mention them. So
Right. Is that because everybody thinks they suck, or we're just politically, we're the best, we're number one, we're number one?
Yeah, that's a good question. I think, yeah, I think there's a lot of exceptionalism, right? Like the US is better, even though the numbers say we're not, right?
Yeah.
So I think that's definitely part of it.
Yeah, yeah. There's a quote that came to me in the research from our producers that I want to read to you, both of you, and see what your response is. It's by Sandro Gala. It's Dr. Galia. So Sandro Galia. The piece is called Well. To overcome the challenge of special interests that work against the conditions that create health, we need to extend the sphere of what we talk about when we talk about health, so that our conversation includes factors like money, power, love, hate, culture, the environment, and politics. So I think I should have read this earlier because we talked about all of those things, but it seems that you two aren't the only ones thinking about this. Obviously, there are other people in the medical profession who are thinking about this. I still remain only a patient, not a healthcare provider. And I still remain, what did you call it? Healthy. I have healthy mistrust of the people who care for me. And I'm reaching an age where I need either to have an advocate with me, not that I can't answer all, but I always walk away from the doctor's appointment with 12 questions, because I can only see the doctor for 6 minutes. So, and there have been times when the doctor went to leave the room and I grabbed her arm. Like, no, I pay a lot for this insurance. So
Right. Right.
my income to have world-class healthcare in this country.
So difficult of you.
I just rabble rouser, and I said,
I know.
I don't know what's going to cost, but I need 6 more minutes.
Yeah.
And she started to laugh, and she stayed. Like, I'll write you a check, but I need more time.
Right.
So I do have that healthy mistrust. I know we're running short on time. We want to get to audience questions, but I want to bring in the COVID-19 vaccine. I live in a community of people who are skeptical of it. I've had both shots. I'm skeptical of a booster, and people are not getting their children vaccinated for fear of this is not really a vaccine. This is because there's no live virus in it. And in this healthy mistrust, in reimagining the trust or the lack of trust we had, what does this period of time mean to both of you when the vaccine is the number one political issue right now? And I'll start with you, Kelly, and then go to you, Dr. Berger.
So we are seeing it in the community here. Sure, Louisiana has some very low vaccination rates, and I think people like to blame it on us being a red state per se, but a lot of that, when you get into the community, it is in the African American community, the questions, the mistrust, is this Tuskegee all over again? Yeah. And are you really trying to help me, or are you experimenting with me again? And we've seen it, and it's actually has a negative effect on the donation side too. So that when we are in the hospitals, there's this whole COVID mistrust piece, and then we get put into the mix, and in cases where it's possible to be a donor, and we're finding now where we didn't see, in 2019, we're seeing these declines in our African American authorization rates on donation. The staff haven't changed. They have more training, actually more years under their belt. The hospitals are the same with their staff, only now they're maybe not as one-on-one or time given to patients. And really that one factor is COVID and all of the mistrust that surrounds it as a virus, and then the vaccine itself. I see it within my staff. So it is bringing up some old thought processes, and at least in my view, it's making that mistrust even greater.
Mhm. I think it's sad that people don't want to give the gift of life because of the mishandling of the information around this. Around
Yeah,
this
they're
virus,
tying it together.
tying it together.
Mhm.
Dr. Berger, your response about COVID and this vaccine and the healthy mistrust, and what do you see?
I mean, I think a lot of the issues related to COVID and vaccinations are pre-existing, and not the disease itself, but people's willingness, or as I mentioned before, the constraint on their choices that makes them choose certain things. You know, you mentioned that the political discussion is all about vaccines. That's absolutely right, and that's a real shame, because as we learned back in 2020, which seems like an age ago, but was only 2020, right? There's lots of things that contribute to the pandemic, right? If you have to work and you can't stay home, right? If you're taking care of somebody who's sick, if you yourself can't take time off work, if you don't have enough food, or if your housing is unstable, or you can't make it to the doctor, right? All these things, right? And there was a brief time there where politicians were actually talking about economic stimuli and sending people checks, but that seems to have been forgotten, right? I'm not hearing that.
They got tired.
Right, that's exactly right. That's what I'm saying.
We're tired of thinking about it, so
That's exactly right. No, you're
hear it on MSNBC, but we're not going to help you economically anymore because
that's right. And that's why the line is the vaccine matters the most. Even when you hear, I mean, Omicron, right, the new variant that we're all scared about, and I'm rightly worried, I think. Biden's response is, well, we have a plan, and it's more boosters.
Yeah.
And he has some other things in the plan too,
Right.
but it's really vaccine centric. So I think people understandably, when you're telling them to do something, go get vaccinated, but you're not offering them anything.
Right.
There's a mismatch. There's a mismatch.
Or you told me to go get vaccinated, and then you tell me a month and a half later I need to get vaccinated again. You're not telling me everything that I need to know to make an intelligent choice. I want to open it up now. Thank you both very much. I want to open it now to our audience. And Erica, do we have questions from the audience?
Yes, we do. Our first question: can those that refuse vaccination get on the donor list? If not, do you have thoughts about this, and how does this impact trust?
So on the donation side, we actually, vaccination status really isn't even looked at if you're a donor. Now an active case of COVID, depending on the time frames, could rule you out for organ donation, but there are more and more transplant centers that are starting to transplant some of the organs, particularly liver and kidneys, on a patient that had the infection, but it's not in that 10-14 day window, and their test results show a lower level of the virus present. So on the transplant side, I have heard that there are various transplant centers. I don't know that it's reached every transplant center, but that if you're not vaccinated, you won't be listed. And it comes to that. I don't know if it's universal just yet, but that has been talked about, and I've certainly seen some media pieces where people wouldn't be listed because of it. But they're immunocompromised when they do get the organ. It's such a rare gift, and should you do everything to take care of that? It kind of wax and wane. I hope that when people do get organs, that they do everything that they can to take care of it for themselves. And then there's a little selfish part for me, because I really pull for my donor families all the time. But I don't know that in my mind that that's a reason not to be transplanted or not to be listed. I just don't think that that's fair.
Dr. Berger, do you have any response to that at all? Any comment on that at all?
Obviously, I don't have the expertise in the transplant world, but I would say there's a pretty significant literature on what makes somebody a good recipient candidate. And oftentimes what we think makes someone not a great candidate turns out not to be the case. So I'm thinking about people that have substance use disorders, right? There's a lot of literature about, if you're still drinking, right, you shouldn't get a liver, right? And there's some literature indicating that's not necessarily the case. So trying to understand where people are coming from. Again, I am a big believer in vaccinations, and I think it's an easy call for me personally. And I'm a big believer in trying to make them easy rather than before trying to make them mandated. But so that's my thoughts.
Okay, thank you. Erica, do we have any other questions?
Yes, we do. From your experience, what would be a recommended forum for all participants within the healthcare system to begin the process of co-work? And can we level the playing field to get the conversation started?
Dr. Berger?
That's a great question. I think a forum has to be in the real world, in the organizations where the work is taking place. I think conversations like this is very important. I think conferences and meetings are very important. But I think unless you have real conversations with real stakes in the places we're talking about. So just to give an example, right? What would it mean for an organization to allow open conversations about pay rates for the least paid workers, right? That would be a real conversation. You get people feeling bad, unfortunately, right? You get people pointing fingers, right? But that's co-work, as my co-panelist here said, right, is messy, and that would be messy.
Yeah, but necessary.
But necessary.
Necessary. Kelly?
I think you have to have those messy conversations in order to get past the roadblocks we're at now. And I do think, how do you want to get to the people that actually want to do the work. And I think sometimes I love conferences when they're valuable and when I take nuggets home, right? Not when I just go and hear the same thing I've heard over and over and over again. And so I think, and then you tend to see leadership at those conferences and not the people that are, in the weeds and in the mud and doing the work. And I think that's backwards, right? Do they even come home and spread it down and out to everyone? And how do you make that available? So I think the conferences are great, but let's give those conferences to the people that are actually doing the work or want to do the work. And I think that's the place to start. And I know you have to have leadership and support and all of that goes with it. But I think that's where leaders need to recognize that you're not the be all and end all in this either. You need the teams, you need your staff support, you need your community support. And
You need the guy with the mop.
Yeah, what does that look like? And I'm with you. That's the person I talk to, because that's who I'm comfortable with. I tell you, when I had my child, the only person that made me feel comfortable and got through my tears after that whole baby delivery thing was a certified nursing assistant. Everybody else I kicked out of my room, and she's the one that stayed with me. And because she spoke to me like a human being and just made me feel comfortable. And so I think that you overlook that human element. And I think those are the people that are going to move this process forward. That human element, the ones that aren't afraid to get dirty, the ones that aren't afraid to explain where they've been in their lives and what they see in their communities and what changes need to happen. And I think on the back end of that, leadership needs to listen. Whether you've experienced it in your life or not, you need to listen. You haven't, been everywhere. And those are the staff that are really going to make the difference.
Yeah, I love the fact that you both went back to power to the people. We have time for maybe one more question. Erica, do we have one more?
Yes, we do. So last question. We need to have communities experience wins along this journey in building trust. Share a few actionable initiatives which would serve this need.
I need to think of some wins. So I mentioned one win where one institution is giving more money to its community. I think that's a win. I think there is some real exciting work going on in the spaces of, and so in New York, I recently read about safe consumption spaces, right? These are spaces where people with substance use or substance dependence can use the substances they need to use for their health in a protected and safe environment. I think that's an amazing thing. And, the incoming mayor of New York, for him to support that. I think that's a big thing. So that's a real win for a community that really helps people living in the shadows take control of their own lives. And that's something that really requires you to understand people's experiences. So that's a good thing.
Kelly?
That's a tough one. I think, whenever we have a patient that gets a kidney transplant, and it's somebody that had been on the list for 5 or plus years, and they're African American, and everything worked against them, and yet here they are, the success story at the end of that transplant. And I think we need to share more of that. That there are opportunities for transplantation, and it can be successful, because I do think sometimes dialysis patients don't see that it's ever going to be successful, right? Like, I think that they think a life of dialysis is just what it is, and I have to live with that. And so I think maybe being able to show some of, at least from the donation and transplant centers or transplantation side, that there can be wins for people, whether you're African American, whether you're Hispanic, whether you're Asian, a Pacific Islander, whatever that is, that you can be transplanted, and it can work, and whatever other things you think they don't exist, or maybe we can help you work through it, but it has to be through the eyes of the people that have actually experienced it, and not through my eyes, but through the actual recipient that sat at that dialysis center 3 days a week, and for 5 years, and went through it, and then be able to explain what it is to get a transplant. Because I think sometimes they know what dialysis is, they don't know what post-transplantation is, and I think that can be scary when you're really cynical or skeptical of anything in medicine. And so I think just showing those kinds of wins, I think being the clinics that we talked about, right? The local clinics, boy, wouldn't that be fabulous if one of those could be established, and then you could really promote how successful. I think New Mexico has actually done some things in line with that. Yeah.
Unfortunately, running out of time. I could talk to the two of you for another hour. I have a notebook here that has a list of other things we didn't even get to. So I'm hoping that the producers will invite the two of you together back again. I do want to thank all of our producers, Kareem Ali, Samuel Sharif, and our wonderful Erica Christie, who manages all of us, for being here today, and for you, the audience, for coming in and listening and being part of our conversation about reimagining the trust issue, the ethics issues around health and our health caregivers. To all of the people who live on the front lines, a special thanks to you for that, from the guy in the mop to the nursing assistant and the people who run the clinics. A special thank you. We thank you for your service. I'm Joya Jefferson Nuri. I was your navigator for today, and it was my pleasure. Thank you all very much, and we'll see you in January.